Welcome. The following presentation is from a satellite symposium presented by Answers in CME, held during the European Association of Urology Annual Congress, titled HER2 in Focus, Guiding Bladder Cancer Treatment Personalization in the Era of Antibody-Drug Conjugates. To access the full program and supporting materials and to claim your certificate, please visit the activity URL in the episode description. This activity is supported by an educational grant from Daiichi Sankyo.
A focus on HER2, titled HER2 in Focus, Guiding Bladder Cancer Treatment Personalization in the Era of Antibody-Drug Conjugates. I'm Andrea Necchi, I'm a medical oncologist from Milan, Italy, and I'm pleased to be joined today by Professor Johan Loriot from Paris. So we will navigate in the next hour through the landscape of the ongoing developments with regards to targeting and more in general on the ADC developments in urothelial bladder cancer. We will span from the non-muscle invasive, muscle invasive, and metastatic disease. So please let's make this debate interactive. So please feel free to interrupt us and to make questions. There are mics that you can use on the in this room. So please feel free to comment. These are my disclosure, and these are the questional objective of this today's meeting. Upon completion of the activity, you should be able to understand more on the HER2 targeting and then framing the HER2 development in the context of urothelial cancer development. It's a busy context today, so we will try to navigate through the pathway for the patient. This activity is supported by a grant, an educational grant by Daiichi Sankyo. The program is CMA accredited, so please do not forget to download the app. You will have the possibility you see on the seat to download with the QR code the app related to this meeting. Downloading the app is important because it will provide you with the possibility of getting the credits at the end, but most importantly, to provide questions, to which we will try to provide answers, and enjoying the overall possibilities that you will have throughout the session in getting answer to a certain question and to participate more lively to the entire session. This is for sure also addressed to those who are attending online and who can send to us directly during the presentation question, comments that we will try to address at the end of the session. So this is the QR code that to scan in order to download the app. So let's start with HER2 as a fundamentals. So from biology to the meaning of HER2 expression, the biology, the underlying biology and the biomarker detection, the way of assessment HER2, the way of testing, and the proportion of patients who are found to be positive, and so on. So let's start first with the fundamentals of HER2 biology. I leave the word to Johan. Please, Johan.
Thank you, Andrea, and good afternoon, everyone. So HER2 in cancer, it's not a new story. HER2 is a well-known target in different solid tumors, in breast cancer, gastric cancer. So HER2 is a receptor, membrane receptor, which activates some downstream cell signaling. And HER2 is derived from the gene called HERBB2 that you can find in the chromosome 17. And it's a key EGFR family receptor involved in tumor growth, cell proliferation. And we can find in oncology and solid tumors a lot of genetic alterations, so mainly amplification, but also mutation and sometimes HER2 overexpression without any amplification or mutation. But anyway, when there is an alteration in HER2, usually it activates cell signaling in downstream. So mainly PI3 kinase, AKT pathway, MAP kinase pathway. And overall, when we activate this cell signaling, usually it results in cell proliferation and invasiveness. And also there is some data from clinical study and preclinical studies suggesting that actually the HER2 positive tumors can also promote some level of immune evasion, and so suppressing the anti-tumor immunity. So one big question in how we can score the tumor with regard to HER2 expression, and you know that there is different algorithm, different way to score HER2. One is used in breast cancer, one is used in gastric cancer, and the question is which one we have to use for bladder cancer. And actually, we should follow the gastric algorithm. So here on this slide, you can see how we can score HER2, so in gastric and bladder cancer. So the score move from 0 to 3, so 0, 1 plus, 2 plus, and 3 plus. And what we have to take into account is the reactivity of the staining and the number or the proportion of cells that stain the antibody. So if there is no reactivity or any staining, but less than 10% of tumor cells, the score is 0. So we say it's a HER2 0 tumors. If we can find a weak or partial or complete membranous reactivity in more than 10% of the tumor cells, it's 1 plus. If the pathology is that there is a moderate or complete basolateral or lateral membrane reactivity in more than 10%, again, is 2 plus, and that's something specific for the 2 plus we will discuss in a few seconds. And if we have a strong or complete basolateral or lateral membranous reactivity in more than 10%, it's 3 plus. So one specificity if we have a 2 plus. So if we have a 2 plus tumors, we have to do another test. So the dish or so fish, we have to find if there is a gene amplification. So if there is no amplification, we'll say, okay, it's a HER2, but fish negative or dish negative. So it's a HER2 low tumors. But if there is an amplification from the dish or ish, we will say that the tumors is HER2 positive, so HER2 2 plus, but fish positive. So it's very specific for the 2 plus tumors. So if we apply this algorithm to bladder cancer, so what is the epidemiology of HER2 expression in bladder cancer? So there is some very good cohort that address this question. Here an example on this slide. So on the left, you can see here some bladder cancer sample from stage 2 to stage 4. And you can see in red the 3 plus, so the high HER2 expression in tumors. And we can find more or less in 15-20% of the tumors. So the 2 plus is quite frequent again, 20-30%, 1 plus about 15%. And in this study, the majority, so 40-50% of the sample, has no staining for HER2. And now, if we use the dish, so the second test, you can find on the right part of this line that we will find an amplification in around 15% of the bladder cancer sample, regardless of the stage. So what about bladder cancer specifically? So we have different stage, the non-muscle invasive bladder cancer, the MIBC. If there is any difference, it's very difficult and challenging to say so far because again there is a lot of heterogeneity in the way that HER2 has been done in the past. But basically, the HER2 is found to be positive in 10-30% of NMIBC, and especially in carcinoma in situ. And in MIBC, we can find again the HER2 expression 40-60% of the MIBC sample. And what is very important to keep in mind that the HER2 expression is very variable in bladder cancer and could change by tumor site, and especially between the bladder cancer and the upper tract disease. And also the HER2 status is heterogeneous over time. So, I mean, if you biopsy the patient for the patient with MIBC and at time of resistance, when the patient, for example, develop metastasis, the status could change over time. So we can have a frequent discordance between the primary and the metastatic lesion within the same patient. I think
it's time to test your understanding. Have you downloaded the app right? Because now you are asked to provide an answer to this question. Which factor most commonly explain discordant HER2 as a result between the primary and metastatic urothelial cancer, supporting the importance of retesting to determine the next step in treatment? HER2 expression can change over time, or expression is altered by prior immunotherapy exposure, or amplification may decrease following chemotherapy. HER2 testing errors. I'm not sure. Please vote. Who has experience in prescribing or in asking for the pathologies for HER2 expression in urothelial cancer? Please raise your hands. Is anyone already experiencing in asking for the pathologies for HER2 expression? Not yet.
Already.
It's a relatively new field, you know. So 75% HER2 expression can change over time. That's right. 80%. That's right. That's a good premise, Johan, I think. So it's fully in line with what Johan has said before regarding the biology of the treatment.
Are you doing HER2 testing in your daily practice?
Well, the difficult question, because I would say no, because there is actually no way of prescribing an anti-HER2 ADC today. But if a patient for some reason could have access, or can pay out of the pocket for a certain commercially available antibody like trastuzumab deruxtecan or DV, and he has exhausted the standard therapy lines, I think it is reasonable to ask. So we usually it's crazy because it's a rising trend, as with the FGF receptor 3 testing. In a similar situation, we still in our reality, in my country, we still don't have the reimbursement over dafitinib, for example. But at a certain point in time, after second, third line therapy, we ask for genomic testing, and the same for HER2 expression, in order to have access somehow to the test. And what
Eh,
about France?
So yeah, so it's highly variable, of course, but in our center, we try to get these results and in similar manner. So I mean, a patient who has disease progression on EVP, on chemotherapy, so late stage, I would say, we test HER2. And the big question is whether we should use the archival tissue to do FRAIR biopsy. So we try to do FRAIR biopsy for many patients, but sometimes, as you know, it's quite difficult and challenging. So we have to use the archival tissue, but if possible, we do a FRAIR biopsy to do this testing.
Great. So you have pretty nicely mentioned the guidelines that we do have today. These are the ASCO and the College of American Pathologists guidelines for gastroesophageal carcinoma. So again, things are not very much different. I'm sorry, not very much different from what has been already presented. So we are a clear positivity, the 3 plus immunohistochemistry that doesn't need any confirmation by in situ hybridization. We have a gray zone of patient presenting with 2 plus immunohistochemistry test, for which we would need a confirmation by in situ hybridization. And we have a HER2 low or HER2 negative test for which there are still concerns when in sending a patient to clinical trials, including patient to clinical trials with the HER2 disease, or prescribing somehow, allowing somehow them to get an HER2 ADC in the real world practice. So on the right part of this slide, the patient could have possibilities to be treated somehow with an HER2 ADC for the remaining part of the situation, and then knowledge should be built already within clinical trials.
Maybe here, Andrea, we can explain the difference between the algorithm that is used in gastric and so in bladder, in breast cancer. So in breast cancer, to say that the tumor is HER2 positive, we should have a staining on the whole membrane. So whole the side of the tumor cells. So, but in gastric and bladder cancer, a staining of the lateral side of the cells is enough. So that's the main difference between the breast cancer and the gastric and the bladder cancer algorithm. I think it's important to have in mind again if you discuss with your pathologist if you want to test the tumor in bladder cancer.
But I think that also what pathologists will need in our reality is a kind of learning curve for
Yep.
urothelial cancer, because in reality, maybe that even by applying the same algorithm in urothelial cancer, things may not be the same in order to read the findings, you know. So I think that we would definitely need to have pathologists embark in our on our side, and pathologists learn to get the best practice in reporting to testing in urothelial cancer. This will likely become a reality in the near future. So the scoring guidelines and interpretation in gastric cancer, you have already mentioned the peculiarities of gastric cancer reporting. Um, it should be noted that the result that you see in within clinical trials using anti-HER2, particularly anti-HER2 ADCs, are results from obtained from patients selected by using the gastric scoring system. That is a pretty it's a pretty consistent way of assessing the tumor across the studies that have been conducted today including urothelial cancer cohorts. So this is a good point, because the data that we have and that we'll discuss in a few minutes are pretty much consistent in the patient population that has been selected, whose tumor has been selected in a uniform, pretty uniform way.
And here there is a so it's maybe a small difference that I would like to stress. So usually we have a surgical specimen, so we can use the algorithm that we discussed earlier. But if you have only biopsy, so there is a very specific point that it is important to point out here, because in the biopsy, of course, you have a tiny sample, and sometimes you will find only some cluster of tumor cells. So the algorithm is a bit different between the surgical and the specimen from biopsy. So you can look here at the slide, and so the scoring is a bit different. The take-home message here is that to do the scoring, you should have a cluster of tumor cells. So the cluster is mean at least 5 tumor cells. So if you find a very weak staining in a cluster of tumor cells with at least 5 tumor cells, so the HER2 will be 1 plus. It's a weak to moderate 2 plus. It is strong is 3 plus. So that's also something you have to have in mind. And because of the heterogeneity that we have in bladder cancer, we advise the pathologist to test 1, 2, 3, or 4 biopsy if possible, because again, usually the biopsy are very tiny.
Thank you. So another case for which you are asked to provide your answer: a 71-year-old patient with metastatic urothelial cancer undergoes HER2 testing using the ASCO-CAP gastroesophageal scoring criteria. You remember the algorithm. Immunohistochemistry shows 2 plus staining, defined as weak or moderate, complete basolateral membranous staining at least 10% of tumor cells. What is the most appropriate next step? First, classify as HER2 positive and initiate anti-HER2 targeted therapy, or classify as HER2 negative, perform a reflex in situ hybridization testing, repeat immunohistochemistry on a different antibody. I'm not sure. Please vote. Let's see.
Good.
That's great. That's great. 100%. So you are already expert, you know. Doesn't need to continue this activity, right?
Probably not.
Yeah. Already 80%, you know. You still have to learn. Yeah. Great. So the answer is clearly that you have to test for the in situ hybridization to make sure that the drug, the target is there in order to use the drug. Please feel free to send comments. The mic are there, or you stand up and address question. Please feel free. No problem for us to be interrupted. Let's make the session as much as interactive as possible. So let's move to the HER2 directed ADC efficacy and the optimization of the treatment. Let's dig into the data. Let's try to move into the clinical trial data. Johan, what is actually going on with regards to the management overall of patients with metastatic urothelial cancer? What's going on?
Yeah, so you know that we did a lot of progress this last 5 years. So here it is the history of the treatment frontline. So I mean in first line. So as you know, we use chemotherapy, the old chemotherapy, platinum-based chemotherapy with MVAC, CISGEM, Tozanzemvac, Carbogem, and then since 2010 or 12, I would say, that we can use in some specific patients immunotherapy frontline, atezo, pembro, usually in cis or in a platinum-ineligible patient. And more recently, we have data that support the use of avelumab after clinical benefit from chemotherapy. And very, very recently, we had two positive phase 2 trial. The first, Checkmate 901, that showed that if you combine cis gem nivolumab, it's better. That's gem alone. And at the same time, what changed the landscape is the EV pembro frontline that improved overall survival, PFS, and increased the response rate compared to chemotherapy. So now it is standard of care in many countries, including here in Europe. So what about HER2? It's not a new question, actually. So we try to develop a lot of clinical trials that assess different drugs targeting HER2, either tyrosine kinase inhibitors, lapatinib, afatinib, for example, neratinib, or antibody. Of course, the trastuzumab, for example, has been developed in clinical trial. Unfortunately, it was an unsuccessful story. So all the trial actually failed to demonstrate any benefit of targeting HER2 in this different trial. In this trial, the drug was given in second line, most of them, or as maintenance, or in combination with chemotherapy. The only trial that actually met the primary endpoint is a very recent trial that combined trastuzumab and paclitaxel in second line. It was a very, very small study with 20-25 patients, but the primary objective was met actually with an overall response rate with about 50%. So pretty good, but very small study. So what you have to take to have in mind is that actually until now, the clinical research for targeting HER2 was unsuccessful.
Do you think, Johan, that the unsuccessful attempts of using TKIs targeting HER2 could be partially related to the low rate of mutations or genomic alteration of the gene?
It
Or
could.
what do you think?
Yeah, I do agree actually. So I think that the amplification and the mutation are quite rare. So I mentioned earlier, it's more and less than 50% of bladder cancer sample. So it's pretty rare. And even you can find an HER2 amplification, sometimes it's not very oncogenic, at least in bladder cancer. So meaning even though you give a drug that target HER2 like lapatinib, afatinib, because it's not very oncogenic,
Yeah.
doesn't result in some benefit for the patient, probably.
You are pretty well familiar of the using ADCs. I guess, how many oncologists are here? Please raise your hands. Who is an oncologist, a med onc? Two guys. And the rest, urologist? Urologist? Two, three, four. Oh, the majority. Okay. And the rest, is there any other specialty here? Radiation oncologist, pathologist? No. Okay. So at least you have heard multiple times about ADC development, particularly in urothelial cancer these days. And at the meeting, this meeting, and using ADCs as in the therapeutic sequence or strategy in patients with urothelial cancer. The structure of the ADC is composed by the antibody, that targets a certain antigen target, like HER2 in this case, but could be Nectin-4 for enfortumab, could be TROP2 for sacituzumab or similar, could be multiple protein. The antibody with the high affinity and avidity for the target. The payload, which is the chemotherapy drug or precursor of the drug, like MMAE or topo-1 inhibitor. Also, we could have multiple options, and the linker, which is actually linking the payload to the antibody, and different linkers may explain different activities or different toxicity of the antibody. So these three uh, components are actually different or shift a little bit between different and ADCs that we are considering today in clinical trials or daily practice, including patients with urothelial cancer. So these are points to be very to have very clear in our mind in order to understand in full what is actually the meaning of the clinical data that we read on the papers and we realize from clinical trials. The mechanism of action of ADCs, at least as far as we know today, is multifold. We have a payload-dependent anti-tumor activity on the left-hand side that could be made via FCFC-mediated stimulation of the immune cells against the tumor and the disruption of receptor dimerization. Most of the ADCs are internalized into the tumor cells. So the payload is released, leading to cell death, and there could be a bystander effect, so a killing on the surrounding cells, the cells surrounding the target cells in which the ADC is internalized. That is a typical effect made by the ADCs, and explain why certain ADCs could have a huge effect, anti-tumor effect in terms of tumor shrinkage in short after the initiation of therapy. What is actually the impact? What is actually the overall impact? Or could we quantify the impact of using RDC, HER2 as an ADC development in patients with urothelial cancer as compared to the backbone of therapeutic option that you have already anticipated you on? What is actually the current situation regarding HER2 testing and HER2 therapy consideration within guidelines?
So there is so it's pretty clear actually for the HER2 in bladder cancer. We, at least in Europe, we don't have any approval from for HER2 directly therapy, so including the ADC. So meaning that the recommendation here in Europe is not to test routinely the sample because we don't have access in daily practice this drug. But the definition of a HER2 positive bladder cancer is clearly the tumors with 3 plus staining the tumors. So basically in Europe, the recommendations that we should use EV Pembro if you have access to EV Pembro in your country, or otherwise it will be platinum-based chemotherapy followed by avelumab or combination of cis gem nivolumab, or if you don't have any immunotherapy, it's platinum and gems are. If the patient has received EV and immune checkpoint inhibitor in second line, again, the level of evidence is very low so far. And so in daily practice, most oncologists use the combination of platinum Gemzar or FGFR inhibitor if there is any mutation or fusion in FGFR3. So meaning that in later lines, you can use erdafitinib, or you can consider trastuzumab deruxtecan if there is an HER2 expression of the tumor, so 3 plus. But again, there is no label in Europe for a tumor agnostic treatment targeting HER2. It is a bit different in US because our colleagues in US are lucky to use an HER2 ADC, so trastuzumab deruxtecan, usually in later stage, so after EVP, after platinum-based chemotherapy. So when the patient has disease progression on the standard of care, but they can use trastuzumab deruxtecan. And again, the requirement is to show that there is an HER2 expression, so 3 plus in the tumor, because the FDA granted tumor agnostic approval for trastuzumab deruxtecan in this setting.
Yeah, you're pretty nicely depicted what the situation within guidelines. We have here the situation regarding EAU guidelines, the latest version of the guidelines in the metastatic bladder cancer, for which uh, consideration has to consider TDXD in the case of HER2 3 plus immunohistochemistry. Although the recommendation is weak, we will see which are the data supporting this indication. Still indicated as weak recommendation because data are being generated by a single arm trial, phase 1-2 trial. We will see later on during the session. And regarding NCCN for unresectable or metastatic bladder cancer, there is still a recommendation for testing HER2 as part of the tumor profiling for eligibility, as Johan has mentioned, for in the US for TDXD. I have a question to you, Johan, regarding the positioning of in the therapeutic sequencing of TDXD, provided that you can have access to the drug, either reimbursed or paid by the patient, whatsoever. But if you know that the tumor of the patient is HER2 3 plus, and the tumor of the patient is experiencing a disease progression during EV pembro, would you consider starting an anti-HER2 ADC at that moment, or would you wait for the post-chemotherapy setting? What is the positioning with regards to platinum chemotherapy, in your opinion?
So, as I mentioned earlier, the level of evidence after, so for a patient who had disease progression on EVP is very low. So we don't have data from phase 2 trial. So in daily practice, we are using platinum-based chemotherapy. But the preliminary result that we have for retrospective studies showed that the benefit is very small, actually. Response rate could be more or less 15%, so pretty good, but the duration of response is very short, so 3 to 4 months. And you know that EV can induce some level of neuropathy, and so sometimes it could be challenging for giving chemotherapy after EVP to the patient. So we have an option with trastuzumab deruxtecan, for example, because here the payload is a bit different. It's not MME, it's so a topo-1 inhibitor, so the safety profile is a bit different. And we know from some data that we will discuss later that we can have some very good response. So in my practice, so if the patient has disease progression on EVP, we test the tumors with regard to at least FGFR3 or 2. If we find any target, we discuss to give so one of the options, so erdafitinib or trastuzumab deruxtecan as compassionate use. Or if there is nothing, of course, we can still provide chemotherapy to this patient.
Thank you. Yes, actually, in the routine management, even in community oncology, we usually say community oncology practice, chemotherapy has become the next second line therapy. So we are dealing with the post EV pembro and chemotherapy basically today. Again, a question to you. According to the current guideline recommendation that you have seen in the previous slides, when is HER2 targeted therapy recommended for HER2 positive patients with advanced urothelial cancer? First, as first line therapy for patients with HER2 expression at least 1 plus, or after platinum based chemotherapy for patients with HER2 expression of at least 2 plus, after progression on enfortumab vedotin and immune therapy for patients with HER2 expression of at least 1 plus, in later lines of therapy for patients with HER2 3 plus disease. I'm not sure. Please vote. We will enter into the details of the data generating this recommendation. But anyway, just to have a sense of your current understanding of the situation. All right, so in later lines of therapy or for patients with HER2 immunohistochemistry at least 3 plus patient disease, 80%, 83%, that's the right direction. So we are currently targeting this patient population, this sizable patient population of patients with urothelial cancer. So let's move on.
Yeah, so now let's look at the data that support this recommendation, Andrea.
Yes, so let's start first from the Chinese data with disitamab vedotin. The DV is an anti-HER2 ADC with a payload which is the same payload of enfortumab vedotin, so it's an MMAE, so a microtubule disrupting agent. Same, exactly the same payload. It's only the target HER2 instead of Nectin-4 that is shifting. We have two clinical trials, phase 2 trials that have been conducted as a single arm trials by Chinese colleagues in sequential ways. The first one, the 005 on the left hand side, included patients who had received at least one previous course of systemic therapy. The other one, the following one, the 09 trial, required prior platinum-based chemotherapy and the taxane. So not the same patient population. On the left-hand side, you see a less heavily pretreated population. On the right-hand side, in the subsequent study, you find a more heavily pretreated population. The distribution of bladder cancer as compared to primary upper tract tumors is a bit different, but not that much to justify maybe a different trend in a different sensitivity of depending on the topography of the primary tumor. The data overall that have been reported and published in JCO a few years ago. It's still one of the most highly published manuscripts that has been presented and published in 2024 in JCO. Raised a lot of interest. So the combination of the two trial data with regards to the primary outcomes, with regards to survival outcomes and PFS is shown here on the left hand side. You see the median PFS values in the two trials separated and in the overall patient population. 14-month median, overall median OS is a pretty nice estimate in a very highly pretreated patient population. The number are still limited, but not that poor. So overall, the data clearly suggests that there is an activity of single agent therapy in this patient population with an acceptable rate of grade 3 on or higher treatment-related adverse events. And we will navigate through the type of adverse events that may occur with the use of anti-HER2 ADCs. But overall, these findings from Chinese population suggested that there was an opportunity to understand more and to use this drug in early disease settings, maybe in combination therapies with an immune checkpoint inhibitor. You see again the results from these two trials and the pooled results with regards to the overall response rate. You see the 50%, 50.5% objective response rate in the combined population is noteworthy. You consider that usually we were used to consider single agent taxane or vinflunin in this patient population. So drug that have reported a response rate ranging around 10%, in between 10 and 15%. So pretty huge improvement with indirect comparison with the standard of care chemotherapy choice. And we do have on the right hand side a nice disconnection on the objective response rate depending on the intensity of HER2 expression. You see on the purple column the HER2 3 plus expression as compared to the 2 plus fish unknown patient population. The objective response rate rise up to 60% or higher than 60%. So clearly noteworthy in this very frail and highly pretreated patient population. Johan.
Yeah, so there is also another trial that assess dizitimab vedotin, trastuzumab deruxtecan. It was the Destiny Pan-Tumor02 trial. So it's an agnostic trial. So the main inclusion criteria in this trial is to have an HER2 expression in the tumor, regardless of the tumor histology, right? So it's an agnostic trial. So in this trial, so phase 2 trial, we can enroll patients with cervical cancer, endometrial cancer, ovarian cancer. In this trial, there was a cohort for patients with bladder cancer, urothelial carcinoma. But again, the main inclusion criteria was to have an HER2 expression, so 3 plus or 2 plus. And the primary objective was to increase response rate. So the primary endpoint was response rate. So if we focus only on the bladder cancer cohort, so 41 patients were enrolled, and so the majority of these patients have 3 plus tumors. But you can see here that there was some discrepancy between the locally assessed testing and the centrally confirmed testing. So maybe we can discuss later. On the right part of this slide, you can see that the patients were heavily pretreated, actually. A lot of patients had received 2, 3, 4, even 5 prior lines before entering the trial here. So the discrepancy, as I mentioned earlier. So you can see here that on the left part of this slide, it's a local testing, and the right, the central testing. So we can see that actually there is some discrepancy, especially for the 3 plus. So after the central review, the number of patients with 3 plus was a bit lower when the patient have initial 3 plus scoring. And by contrast, some patients have a low HER2 expression by the local review, but finally have an HER2 3 plus testing. So meaning that there is probably, as you mentioned earlier, a learning curve to run this testing by immunohistochemistry. So the results are the response rate will be high. We will discuss in the later, but we can focus first on the PFS and overall survival. Again, the patient are heavily pretreated, so receive a lot of prior line, and the median PFS was around 7-8 months, and median overall survival around 30 months, so pretty good for this population of patients. The dark side of the ADC, generally speaking, is the safety profile, because ADC is still a chemotherapy. It's a target chemotherapy, but still chemotherapy, so we can expect some level of toxicity related to the payload. And in this trial for the bladder cancer cohort, around 42% of the patients developed grade 3 drug-related adverse event that we will describe later again. So regarding the response rate, so you can see here that the response rate was pretty good, actually. And in all patients, if we gather all the patients, the response rate was around 40%. But if we focus on patients with 3 plus tumors, the response rate was pretty high, so 56%, and for the 2 plus, 35%. So it seems that here the biomarker does matter to predict the response to the drug. So the secondary endpoints, duration of response, PFS, and overall survivals. Here, the results are more tricky to discuss because it seems that the expression of HER2 does not matter at least the PFS and overall survival. So it is important with regard to the response rate, but in lesser extent for the PFS and median overall survival, and also the duration of response.
So we have a pretty nice question that came from the online audience. I would like to address this point because it's critical to address at this time. So clearly we don't have any data today from trials, but what we know today regarding cross resistance between ADCs, in particular between payloads. So we have seen the DV data, the TDXD data. So in the post enfortumab setting, provided that we don't have any data, but would you be more favorable in shifting the payload to top one agent, or would you be more favorable in continue with the MMA? What do you think?
Yeah, it's a 1 million euro question. So, because actually we don't know the mechanism of resistance to EV. So it could be a loss of expression of Nectin-4, the target, or a resistance to the payload. And we don't have any very good data from biopsy patients who have disease progression on EVP. So there is different strategy, of course. If the mechanism of resistance is mainly related to the target, so I mean, if there is a loss of expression Nectin-4, I think it makes sense to give another ADC that target another protein, but with the same payload, for example. But if the mechanism of resistance, the main mechanism of resistance is the resistance to the payload, of course, it makes sense to maybe to change the payload, but still targeting the same target, so Nectin-4. And actually, we don't know. There is some clinical cases reported that show that in some patients, at least, if you biopsy the patient at time of resistance to EV, Nectin-4 is still expressed. So suggesting that maybe what you have to do is to change maybe the payload and not the target. But it's just some clinical case, but not big translational study. So coming back to your question, we don't know. At ASCO GU, so a few weeks ago, there was the trial with DDT-MEM vedotin, the phase 2 trial. And so DDT-MEM vedotin, as you mentioned, as a MMA as a payload. And in this trial, some patients receive EV at, I would say, in later line, and the response rate was very low. So suggesting that we can face some level of cross resistance between ADCs that share the same payload. Yeah, indeed.
Thank you. So we have seen before the phase 2 data in a late stage metastatic urothelial cancer with DV. These data supported the performance of a phase 3 trial, Chinese trial, with a combination of DV and toripalimab by Chinese anti-PD-1 agent in frontline setting in patients with locally advanced or metastatic urothelial cancer. This is a trial very much close to in the design to the EV302 trial, which tested the EV Pembro versus standard of care chemotherapy and resulted in EV Pembro becoming one of the therapeutic options that we have today. The trial design is pretty much similar. Untreated chemotherapy, untreated patients, and immune therapy treated patients with the metastatic stage 4 urothelial cancer being randomized to receive DVT on the experimental arm, or gemcarbo or gemcis in the control arm. There was no maintenance avelumab in this trial, fully mirroring the situation of Chinese patients. In China, avelumab is still not approved, so patients were receiving at that time as standard of care just 4 or 6 courses of platinum chemotherapy as a standard of care. The endpoint, the primary endpoint was PFS and OS, a co-primary endpoint. There was a stratification here. The trial population was in particular with regards to HER2 expression is shown here. About 20% of the patient presenting with the 3 plus test. PD-1 expression also is shown here, and the type of the platinum chemotherapy is half and half, as we would have expected in real world. The shape of the curve with PFS and the same will be for the OS are pretty nicely recapitulating the data from EVP trial frontline, both with regards to the experimental arm DVT as compared to EVP, and also with regards to the standard of care chemotherapy, implicitly showing that HER2 selected population was not actually determining the difference in the outcome of the patient. So HER2 not resulting in any particular prognostic significance here in this patient population. This is a patient population selected for HER2 test. Important to say that as compared to the EV Pembros trial, this is a population that was selected for HER2 expression by including 1 plus, 2 plus, and 3 plus. So just excluding the 0, no expressors from the trial inclusion. All the rest of the patient have been included in that trial. And in fact, if you see the screening failure rate that is being accessible in the paper. The paper has been published in the New England Journal of Medicine just a few weeks after the ESMO, or simultaneously to the ESMO presentation. We had only around 15 to 16% of the patients who were excluded from the trial inclusion, from the randomization, due to the lack of expression of HER2. So a very, very limited population not being included in this trial as compared to the all-comer approach of EV-pembro. Results in terms of objective response rate are pretty much recapitulating the EV-pembro data. The disease control rate the same, and PFS and also OS was not primarily dictated by the HER2 expression. So the hazard ratio is pretty much stable regardless of the HER2 expression level. This is good on one side, this is bad on the other side. Johan, what do you think? When you have to select patients between multiple options being available tomorrow to our patient, EV-pembro, DVT, or DV-pembro, not having a biomarker that enable us to select more robustly the patient population who may benefit the most from select therapeutic option, is it something that could be regarded to as concerning, right?
Yeah, it's a problem because if we have two ADC with the same payload, but no biomarker that can be helpful for the clinician to use one or the other one, of course it's a problem for us in daily practice. Here, I think it's important the problem of developing a good biomarker. We have seen that for trastuzumab deruxtecan, the biomarker is associated with the response rate, not clearly with the PFS and overall survival in a phase 2. And here for dizitimab vedotin, it's pretty clear that the biomarker does not predict anything actually. So it's a problem. So of course,
At least from the immunohistochemistry standpoint.
immunohistochemistry.
Let's see if from the translational data, the genomic data from this trial will something will emerge that will guide us. Johan.
Yeah, so there was also another phase 1/2 trial that combined actually trastuzumab deruxtecan with immunotherapy. As mentioned earlier, that there is a rationale to try to combine with immunotherapy, sometimes ADC, and especially the ADCs that target HER2. So there was a phase 2 trial that combined both agents in patients with urothelial carcinoma and HER2 expression. And the overall response rate was pretty good, actually, in late stage, 37% of response, and especially for the patient with high HER2 expression. So here, it seems that the biomarker predicts something when we combine trastuzumab deruxtecan again with nivolumab. And the median PFS was acceptable, 7 months, again in late stage. So in patients previously treated with chemotherapy. So something important to consider here. Okay, so we have reviewed some of the clinical data for the efficacy. So we have a question for you here. So which efficacy pattern has been observed across trial of HER2 targeting ADC in advanced urothelial carcinoma? Number 1, greater activity in HER2 mutant tumors. Number 2, greater activity in the HER2 high tumors. Number 3, activity independent of HER2 expression level. 4, activity primarily in HER2 amplified tumors. And lastly, I'm not sure. Please vote. Okay, great. Well done. Perfect. So now we will discuss maybe how we can sequence this agent and what factor we have to consider to provide some rational and relevant sequence.
Yes, this would imply, or the result that we have seen in the later stages imply the possibility of shifting to earlier stages, non-metastatic, organ-confined urothelial cancer, primarily bladder cancer. Uh, in other words, result in the perioperative setting of MIBC, muscle-invasive bladder cancer. We do have interesting or practice-changing preliminary data on ADC use. On the left-hand side, you see the well-known Kino 905 trial testing a perioperative EV pembro and cystectomy as compared to cystectomy alone in cisplatin ineligible patient population, for which the standard of care is radical cystectomy up front. And you see the curve in terms of PFS and also OS clearly supporting the new therapeutic option represented by EV pembro, with a PCR rate that was higher, much higher than any other combination therapy or single agent therapy that we have provided in clinical trials as of today. On the right hand side, you see a smaller trials, a phase 2 trial, a single arm trials from Chinese colleagues using DVT, the same combination that we have seen in the phase 3 trial, in the perioperative setting. So DVT neoadjuvantly, surgery, and toripalimab as maintenance adjuvant therapy. And you see here that the PCR rate in patients with 3 plus expression raised up to 88%. It was outstanding. What does it mean? We still don't know what is actually the meaning of such a high rate of PCR, but for sure, possibilities to use these agents in next generation trials, or possibilities of avoiding in select patients the possibility to undergo radical cystectomy in responders. Uh, in general, if we see the entirety of the what is going on in organ confined disease, including non-muscle invasive disease, we start from the BCG, the high risk BCG naive population, with the data from CREST, Potomac, Alban trial, overall supporting a possible use of immune therapy in combination with BCG. We do have the data in muscle invasive disease, except for 905. We have the Niagara trial with durvalumab gemcis and adjuvant durvalumab. And we quite recently had, a few weeks ago, in the GWASCO, the B15 trial in the cisplatin eligible population, patients receiving EV pembro, as compared to keep standard neoadjuvant chemotherapy, got the survival advantage, PFS, EFS, OS, and again a PCR rate reported as high as 57 or 56% in this patient population. And we do have adjuvant possibilities in Europe in PD-L1 positive patients with Nivo, in our camera with Nivo in the United States. We have a ctDNA guided approach with atezolizumab, just presented at ESMO last year. So all these developments are impacting, will likely impact the way we treat a patient who will be diagnosed with the metastatic, local advanced or metastatic urothelial cancer, as most of the patient, the vast majority of the diagnoses in urothelial cancer are made in non-muscle invasive and muscle invasive stage, 80% of the diagnosis, if not more. So it's more than likely that we have to shift a little bit our state of mind, our way of thinking regarding the frontline therapy on patients with metastatic urothelial cancer. So lastly, the HER2 toxicity, the HER2 ADC toxicity, which is an important point to make when it comes to the sequential therapeutic approaches and consideration on patient management. So Johan, what is the ideal patient for which we have to use these agents?
There is no clear response to your question, but at least we know that we should select a patient based on HER2, so 3 plus, and selected 2 plus if you have FISH positive. In terms of disease setting, it's metastatic, post-immune checkpoint inhibitor, and post-platinum-based chemotherapy, or post-EVP. And prior therapy should be used, actually. So we said that we can select the patient with who receive a lot of prior lines, so late stage. And of course, the patient should be in good shape to receive a new ADC in this disease. So we have 2 different drugs, so trastuzumab deruxtecan and tisotumab vedotin. Because the payload is different, the safety profile is different. For trastuzumab deruxtecan, we can expect some level of nausea, diarrhea, anemia, neutropenia, because the payload is a topo-1 inhibitors. While with tisotumab vedotin, what we can expect is the neuropathy, because the payload is MMAE. So it's the main toxicity that we can face with the tisotumab vedotin.
Well, the safety of HER2 ADCs in the bladder cancer is pretty uh, summarized here. Uh, well, overall, the two drugs have been reported to be very well tolerated. There is a concerning or a red flag that is related to the interstitial lung disease with the use of TDXD, implying that there is the need to have an ideal assessment by pulmonologist before starting therapy, just to exclude the pre-existing causes of possible development of ILD in this patient population. So performing, again, as we said at the beginning of the story of EV in the urothelial cancer, a multidisciplinarity, a multi-specialty evaluation of the patient, in this case by pulmonologist or maybe other specialist, is likely required prior to start the treatment. Yuan.
Yeah. So if we have a patient who developed the ILD or so pneumonitis, the management is pretty clear. So if it's asymptomatic, if you find actually an ILD on the CT scan, what you have to do is to stop and hold trastuzumab deruxtecan, and you consider to give steroid to this patient, 0.5 milligram per kilo, for example. But you can resume the drug if the toxicity come back to zero, so to baseline. And then you can maintain the patient on the same dose if the toxicity see if the patient recover in less than 1 month, or you have to consider dose reduction is more tricky. So I mean, if the patient recover in more than 1 month. But if the patient is symptomatic, you have to permanently discontinue trastuzumab deruxtecan, and of course you have to treat the pneumonitis with steroids, so at least 1 milligram per kilo per day, and then you have to taper the steroid. And you cannot, in this scenario, you cannot re-challenge the patient with trastuzumab deruxtecan. So the take-home message here is to monitor very, very carefully the patient with a baseline CT scan and other CT scan, because of course the pneumonitis can occur without any symptoms. For disitamab vedotin, so the main primary the neuropathy. So if there is a grade 1, you can continue the treatment. You can consider some level of support, but the level of evidence is pretty poor for this support care. If the patient develops a grade 2, clearly you have to hold the treatment. You can give some drug like gabapentin, for example, and to discuss with some neurologists if there is very specific to do. But in this situation, you can resume the drug if the patient recover a bit at a reduced dose, or you can extend, of course, the interval.
So last question to you. A patient receiving TDXD for metastatic HER2 expressing urothelial cancer develops grade 1 asymptomatic treatment-related pneumonitis. Therapy is held and the corticosteroids are given with complete resolution after 5 weeks. What is the most appropriate next step? Continue TDXD with dose reduction first? Continue TDXD at the previous dose? Discontinue TDXD and switch to DV? Discontinue TDXD and switch to chemotherapy? Or I'm not sure. Please vote. Let's see, 50% continue TDXD with dose reduction. That's good.
Yeah, because the patient recovered quite late, so after
Yes.
4 weeks. So actually, so we have to do a dose reduction here.
And grade 1 asymptomatic side effects, so mild toxicity. That's great. So opportunities and challenges, very briefly, we have different approvals today. In China, DV is conditionally approved. In the United States, it has been granted FDA breakthrough therapy designation after platinum chemotherapy. In Europe, it's still not approved. It's an investigational agent. So things are changing quite rapidly depending on the clinical trial data. So it's very difficult to foresee the future. The future means tomorrow, because it's a very much trial dependent, and the entirety of the sequential data with multiple agents are still being developed, and they're still a matter of development, also including the early stage disease that may impact on the later lines. So for ADC antibody, there is a clear polarization of the developments. between China and United States. This is pretty much concern for us as non-China, non-US residents, because this would imply a kind of jeopardization and a kind of an increase in geographical disparity in patient access to effective therapy. So it's something to consider whenever we are part of the development plan of certain drugs. So in conclusion, we have to say that there is clearly a signal supporting HER2 directed ADCs, either with TDXD or DV in patients with urothelial cancer. HER2 testing the HER2 testing consequently is expanding. We still have to have the pathologist fully embark in this process. The learning curve is necessary, as we have discussed, and an homogeneous way of reporting the HER2 expression is of paramount importance when trying to select patients for these possibilities. Access and equity of these drugs, as well as with other new drugs that are emerging today in urothelial cancer, is of paramount importance. We are discussing at the forefront of the developments, but please don't forget the fact that the vast majority of the patients diagnosed worldwide with the urothelial cancer are far behind this forefront development. So we have to take into account the entirety of the diagnosis worldwide of urothelial cancer and take into account the geographical disparities in patient access to newer therapies. Having said that, I think that we are running a bit out of time. So if you have any burning question, any comment, please feel free to provide your comment or question. Otherwise, I think that we have to close this session. So Johan, I think that it's an exciting story that we are building today all together, and it's great for the patient side. It's great advances for the patient.
Clearly, new options.
Yeah.
Yeah.
So thank you for your time. Thank you for being here on the Friday afternoon, Friday evening, during the busy EU meeting. Please don't forget to complete your evaluation. Scan the code and provide your feedback. And download the slides. You will be able to download the entire slide deck with the use of the app, so you will enjoy reassessing the slides and your knowledge on this topic. So we would like to thank the NCLC and CMA for hosting this nice event, Daiichi for supporting the event. I would like to thank Johan.
Thank you, Andre.
For co-chairing this session, and all of you for attending. And please enjoy the rest of the days and the rest of the Congress. Thank you very much.
Thank you.
Thank you for listening. Please visit the activity URL in the episode description to view all program materials, complete the post-test, and get a certificate.